Good evening to all. This is Ranjit Sahu, Marketing Head with Walter Bushnell. Welcome you all to this live webinar, Indo-International Web Series 7 in association with RCOG Indian Liaison Group presents live webinar on urogynecology. With this, I hand over the session to Jyoti ma'am to take it forward. Over to you, ma'am.
Thank you so much. Thank you, Ranjit, and thank you, Walter Bushnell. And on this pre-Valentine Eve, I welcome you all on this platform in amidst this love of air of love on this webinar as well. And this is our 7th series of Indo-International Web Series in association with RCOG India Liaison Group. And this particular webinar today is being focused on something very difficult, a topic very difficult to most of us, on urogynecology. And for this, we have our international coordinator, Dr. Jyotsna Pundir, who has been the main force behind it, and our convener, Dr. Lakshmi Srikhande, who has been actually doing everything on the Indo half. And I welcome Dr. Lakshmi, who is the consultant and director at Srikhande Hospital, to please invite our international coordinator, Dr. Jyotsna Pundir, and say a few words before we move on.
Wow. It's a pleasure and privilege to invite Dr. Jyotsna Pundir, who is our international convener for this Indo-International Web Series. And Jyotsna, here I invite you for your opening remarks and further proceedings. Yes.
Thank you, organizers and Dr. Lakshmi. This is the educational event which we are all very passionate about. And unfortunately, we lost one of our esteemed colleague, Dr. Sanjeev Sharma, recently due to COVID. And we wanted to take this as an opportunity to pay our respects to him. And I think this is one of the best platforms because he was very, very passionate about education and training. I would like to introduce Dr. Manisha Singh, who has worked very closely with him, and she knows him far, far better than many of us. She is a reproductive medicine specialist, worked here at St. Mary's Manchester Hospital, and now she has gone back to India, and she heads the unit at the Fortis, Bangalore. Manisha, thank you so much for accepting our invitation to speak to us about Dr. Sharma, as not all of us who are in the UK or in India do know about a lot about him. So we're really, really grateful for you accepting to talk about him. Once you have spoken about him, we will all take an opportunity to light a candle and maintain 1 minute of silence in respect of him. And then following his wishes as an educationist, we will carry on with our education event. Thank you very much for providing us this platform, Dr. Lakshmi. To you, Manisha. Thank you.
Namaskar and good evening to everyone. Thank you so much, Jyotsna, for your kind words and for this invitation. Thank you, Dr. Lakshmi Srikhande and the RCOG India Liaison Group for allowing me to give an eulogy to my guru, my mentor, Dr. Sanjeev Sharma. Sometimes a chance meeting can change the course of your life. And that is exactly what happened with me. My thoughts go back to a meeting in 1995. I was a year post MD and post MRCOG Part 1, and very keen, like so many of my friends and colleagues, to come to the UK for further training, in view of which I attended this meeting in Delhi. And I still remember after the morning session, I was standing in the lunch queue. And there was this gentleman who was stood behind me. And since the queue was very long, he greeted me and he said hello. And he asked me who I was. And I introduced myself and I said, I am Dr. Manisha. and I'm very keen to come to the UK, which is why I have come for this meeting. What about you, sir? And he said, I'm Mr. Sharma, and I'm a consultant in Liverpool, but I'm basically from Delhi. So since I was visiting family, I'm here for the meeting as well. He said, have you applied for a training job? And I said, yes, I have. And I'm on the Overseas Doctors Training Scheme, which is the ODTS. So in those days in 1995, I'm sure many of you must relate with this. There were two schemes operating from the RCOG. One was the double-ended sponsorship scheme, and one was the Overseas Doctors Training Scheme. Of course, I wasn't lucky to know anybody in the UK, so I went on to the ODTS scheme, the waiting times for which were about 18 months in those days. So he said to me, have you sent your CV across? And I said, yes, I have. Do you have a CV on you, Dr. Manisha? And I said, no, I don't, because I just came for this meeting. He said, okay, this is my card and this is my address. In those days, we didn't have email. So he said, why don't you post me your CV? And I said, sure. And we just got about chatting about different things. And when I came back to Bombay, or Mumbai as it is called now, I sent him a CV without much thought. I didn't think that, anybody would do anything. But anyway, I thought he was a very generous and kind-hearted person who had asked for my CV. And so I mailed him a CV. This was in March. And in May, I got a very strong rap on my knuckles in the form of a letter from the RCOG saying, you are on the ODTS scheme. How can you try and find a sponsor for yourself? And I said, well, what sponsor? I had forgotten about it. And they said, well, there is a Mr. Sharma who wants to offer you a job in South Port Ormskirk Hospital. And he will not have it any other way. And he's told us categorically that you are coming in the August training scheme. And that was that. I mean, suddenly I had a job. I mean, where I was in March, I didn't have a job in the UK. I was working as a lecturer in Sion Hospital in Mumbai. And here I was going in July to the UK, thanks to this gentleman I met in a lunch queue in Delhi. And of course, in those days, you could only take 35 kilograms luggage when you flew abroad, even as a student. So my parents, who were flying to the States, decided to take one bag of books with them for me in June. And they were received by Mr. Sharma, and he very kindly agreed to keep my bag of books in his house. And of course, when I reached there in July, he was very gracious enough to host me, him and his beautiful wife, Dipali, and their little daughter, Rayona. And subsequently, I started my training. One of the few things, he was a man of few words, but what he said was pure gold. And you just held on to those words because those words would take you very long. He said to me, you're very fluent in English, but the words you really need to know is please, thank you, and sorry. Remember these words, use it as much as you can in your sentences, and see the difference it makes when you communicate with people, because communication is the most important thing. Through the years, 1995 till 2011, he was my guide, my mentor, my guru, my very first referee in every single job application that I made subsequently in the UK after I joined the South Port Ormskirk General Infirmary. There was no looking back because he said, you must aim for the skies. Do not apply for an LAT post or a fixed term training post. Apply for an NTN number. Those were his words, and I did so. And I was lucky to get a job both in Cardiff and Cambridge. And he said to me, go for the Cambridge job. He guided me all the way till my subspecialist job, till my consultant post. And even when I was leaving for India, I called him up and I said to him, sir, and that's what I called him, sir. I was never able to call him Mr. Sharma because you can't say that. That's what you say in the UK, but I always called him sir. And he said, this is the right thing to do. The NHS is changing. Go back to India and carve a niche for yourself. A very, very dedicated teacher, a fantastic guide, a person, the kindest person I have known. And if you were to ask anybody, the only thing they will have to say to you about Mr. Sharma was that he was a thorough gentleman. He must have guided so many students, aspiring students from India, given them jobs and taken them through their careers. I think the list is endless. There will never be another person like him, the most kind-hearted soul. And it's an absolute tragedy the way he passed, because he recovered from the first round of COVID in 2020. And for him to come to India at the beginning of January, to see his family, because he hadn't seen his family for more than 2 years, thanks to COVID, to come here to India, have a second bout of COVID, and then to pass away from GI complications is an absolute tragedy. I'm totally heartbroken, but all I can say, he was a punyatma. He was a noble soul. He was a blessed soul. And I'm sure his atma will attain moksha, because they don't make people like him so often. It's once in a millennia that there is a soul like him that comes across and goes out of his way to help, guide, train, teach students, doctors, care for patients like he did. And I can only pray that his Atma attains Sadgati. Thank you very much for giving me this privilege to speak about my guru, Dr. Sanjeev Sharma. Namaskar.
Yeah, that was very, very touching, Dr. Manisha. And I mean, it is just...
Thank you, Manisha. Jyoti, if you don't mind, we'll just take 1 more minute. So all of us are going to light a candle and maintain silence for a minute in respect to Dr. Sanjeev Sharma. Please do this along with me. And I just got my candle here. Okay, so please, all of you with me, maintain 1 minute of silence and pray for his soul to rest in peace. Thank you. Thank you. Thank you so much. Thank you, everybody who joined this. And thank you, Dr. Lakshmi and Bushnell, to give us this opportunity.
Thank you so much.
Thank you, Manisha. With this, as I said before, keeping his legacy going on, let's go ahead and do this education event on urogynecology. Thank you, everybody.
Welcome, Jyotsna Acharya. Welcome. Happy to have both the Jyotsnas in one frame here.
Thank you. No, he touched me as well when I did the part 3 courses with him. So I really did want to join this. Thank you. Thank you for having me.
Yeah. Yeah, Jyoti, back to you.
Thank you, everybody. And Om Shanti, people who touch us, I mean, they will stay with us forever. So he's not gone, he's still with us. And in his memory, we would be doing this webinar today. And also I would like to welcome our convener for this webinar, Dr. Manjula, who has also joined us, who is a consultant urogynec from Royal State Hospital. So moving on with our first topic of urinary incontinence, we have the chairpersons. Can I have the CV of our first chairperson, Dr. Jaiswar, Dr. S.P. Jaiswar, ma'am? Ranjit, can we have the CVs please there? Or should I share the screen? Okay. So we have, we have CV of Professor Mala. I can read that out first if that is first in the queue. Okay, Dr. Mala can we have it a little in the slideshow, right? So welcome Dr. Malash, who's a senior consultant, Professor GRIP. She is also a gynec endoscopic and robotic surgeon at Sir Gangaram Hospital. And ma'am is a awardee of many awards, APJ Abdul Award, Subhash Mukhopadhyay Award, Women Medical Professional Awards, and a member of many societies, many committees, and she has been the past president of AOGD in 2020-21. She is the vice president-elect ISOPA 23-24. So welcome Dr. Mala to this platform and to chair this important session. And can I have the next CV? No, the first CV, please, of Dr. Jaiswar. Yeah. Dr. S.P. Jaiswar, ma'am, welcome to the platform. Ma'am is Professor, Unit Head, Department of Gynae, KGMU, Lucknow. Ma'am has so many fellowships, awards, a member of wonderful, many important organizations, and she is visiting professor at BP Koirala Institute of Health Sciences, Nepal. She is visiting professor for ICOG and has more than 100 publications. So I hand over to Dr. Jaiswar to introduce our first speaker, and then Dr. Mala to please sum up the session.
Thank you, Dr. Jyoti, for your kind words. Thank you so much. Good evening to all of you. This is my proud privilege to be here and become part of this prestigious international webinar on urogynecology. First, I should pay my regard and Om Shanti, Dr. Sharma. At the outset, I thank the organizer who have given me opportunity, especially Dr. Lakshmi Shikhande, for inviting me as a chair this session of urinary incontinence. As we know, the urinary incontinence is involuntary leakage of urine. Prevalence may vary according to age. Young age can occur in 25%, but as increasing age, it can go up to the 75% in elderly women. And basically, it's divided into three types: stress incontinence, urgency urinary incontinence, and mixed urine incontinence. Now we are going to listen in detail about the urinary incontinence by Dr. Fridlema O'Mahony. This is my honor to introduce Dr. Fridlema O'Mahony. She is MB, CHB, BAO, FRCOG, DipMed Education. She is a professor of clinical education and gynecology. She's a consultant in obstetrician and gynecology and UHNM Hospital. She is dean in UHNM Hospital, KLA Medical School. She is having research training, made research method modules, and she's having lots of research experiences. She's a lead author of Cochrane Review of Instrumental Delivery and having many publications in her credit. Now we are going to listen, and the floor is Dr. O'Mahony.
Thank you.
Hello?
Can you hear me?
Thank you so much, Dr.
I'm just going to see if I can share my slides.
Yeah, definitely. We'll wait.
Okay, can everybody see my first slide?
Very clearly. Very
Great.
Yeah, fantastic.
Yes, we can.
Right. Well, first of all, thank you very much to the organisers and to my colleague, Miss Anapa, for inviting me to share this meeting with you. I was very touched by your eulogy to Mr. Sharma. I have to say his ethos is one I hold very dear to my heart. As the chairperson has said, one of my remits is medical education. And as such, I spend an awful lot of time delivering and managing education at the university and the hospital and locally. I think this, you rightly say, is a very challenging and relevant topic. I think it's a very neglected topic. But what I think is really encouraging, if we go back to our basics, is that urinary incontinence is something that can be really well managed by remembering what we all learned in medical school, which is essentially to listen to our patients, take a good history and examine them. So I am going to deliver what I hope is my take on the subject. It is an enormous subject, and no amount of time would do justice to it. I'm not going to specifically quote the literature or quote definitions or textbooks, because I think in our clinical practice, we actually deal with the individual patient as how she presents, rather than formally referring back to textbooks. But I have to emphasize over and over again that the basics of clinical history taking and examination are core here. So this is an enormous problem worldwide. I think the etiology and the contributing factors and the management vary from place to place, but women are women the world over. And unfortunately, women are very much second-class citizens when it comes to healthcare in many environments. And in my work in developing countries in charity works, I've seen this all too often. As you mentioned quite rightly, there's an incidence of 26%, and this varies according to location and according to the study size and the quality of the study and the population and how hard we look for it. But in India today, there's at least 50 million women who suffer from urinary incontinence. And the impact of this is huge. And I think with medicine, it's very trendy to say quality of life is the main impact. But actually, that is a little bit of, I think, an opt-out cause. It's very easy to say quality of life issues, just as it's easy to say send everyone to an MDT for management. Urinary incontinence is directly related to falls in the elderly. These are multifactorial and often associated with comorbidities. It's a huge cause worldwide, and particularly in developing economies, of social isolation. It has a huge financial impact, and this is not to be underestimated. And this is a financial impact double-fold. In a lot of areas, the woman is the main breadwinner, and a woman who goes out to work ensures her family is educated, and particularly her daughters are educated. The impact of not being able to work because of urinary incontinence and the embarrassment it causes, or the impact of not being able to buy continence aids or access hygiene, is not to be underestimated. And finally, we of course have the health impact, and the commonest among these are probably recurrent urinary tract infections with antimicrobial resistance, and also local skin conditions, which again should not be underestimated. How we see urinary incontinence, and I make no excuses for going on about the presentation of this, because I think as doctors, the more specialist we get, particularly in surgical specialties, we tend to focus very much on what we can do surgically and forget very much about the woman behind the desk and the woman and the person behind this. So how these women present depends on their circumstances, depends on their confidence, it depends on their personal expectations, their sense of personal value and self-worth. And this, of course, is also impacted upon by the social expectations of women, which varies within countries, it varies within social strata, it varies within financial strata, and it doesn't always follow through that if you've got more money or are better off, that actually your healthcare gets more attention, because that is not a given. There are lots of barriers to disclosure, and these might be social, they might be religious, they might be cultural, they might be physical. A woman may be isolated and can't actually get to access healthcare. And then, of course, there's our attitudes. Are we actually approachable people? Do we communicate with our patients? Do we communicate with each other? Have we got a nurse in our practice who's approachable? Is our receptionist approachable? Can a woman come and say, actually, I've got an embarrassing problem here? And then if she can break down and get past that barrier, do we as healthcare professionals actually have the skills or expertise to listen and to manage these women? And I would put it to you that we all do, and these are basics we learned in medical school. We may have forgotten how to use them, but we all have them. And finally, women ourselves and the medical profession have a lot to answer for with this, because urinary incontinence in a lot of settings has been normalized. And at least 3-4 times in every clinic, I hear a woman saying she went to see her doctor, went to see her nurse, said she leaked, and they went, well, that's to be expected. You've had children, you're past the menopause. It's normal. It isn't normal to leak, and men would not put up with it. So why do women? The impact on a woman's life is absolutely unquantifiable. You've got a fear of smell, a fear of coughing and sneezing. Women toilet map, they go from one place to another. The impact on personal life, and in particular on relationships and sex, can't be underestimated. As doctors, we often don't ask about this, but it's very important. There's embarrassment about wearing pads, whether the pads will contain urine. There's huge limitations on clothing that women can wear. And it can take an awful lot of years before they come to see their GP or their primary care doctor or whoever is their healthcare person to take care, to manage this. And so often we talk to women who have medical problems such as diabetes, heart disease, and we talk to them about going out and taking exercise, and they don't go. And we never ask them, why don't you exercise? And a lot of the time it's because of the fear or the impact of urinary incontinence. So sometimes this is actually an incidental finding. Women present with a urinary tract infection and it's very easy just to treat, but actually ask a little bit more about it. Pelvic pain, a pelvic mass. Is urinary inquiries part of our routine history? And I will put it to you that it should be part of our routine history. We are taught as medical students to do a complete review of systems. And actually, we can't do that in everybody. But when a woman comes to a gynecologist, we should all ask, does she leak? Is she embarrassed by loss of urine or feces? And that is another area completely. We do a lot of screening in our healthcare encounters, and a lot of our nursing processes have got routine documentation whereby they do an assessment on a patient's admission to hospital, often for an elective procedure on continence. But actually, what do they do with it then? It often gets filed away in the patient's notes and we never look at it again. So actually we have the tools, and in a lot of areas and in a lot of well-resourced areas, we're asking the questions, but we're not doing anything about it. So why not say to every woman we see, do you leak? Do you need to wear pads? Is this affecting how you work, how you exercise, how you live? It's very simple. It takes 2 minutes. It's a tick box, and we can pick up a lot of problems. So, as I said at the beginning, taking a history is important. I would say 90% of the women I see, I would say 100% of the women I see never have urodynamics as a first line, and probably 90% of the women I manage never have urodynamic studies at all. And certainly not full urodynamic studies, because it's actually not necessary. We can find out an awful lot about asking about filling symptoms, storage symptoms, but very importantly, voiding symptoms. Because one of the commonest causes of both urinary stress incontinence and overactive bladder is because the bladder is full. So it's continually irritable, or it leaks every time you cough or sneeze or move. So actually, voiding symptoms are probably the one I ask about first and foremost. And it's very easy to think about the woman who says she has urgency and goes to the toilet 20 times a day and gets up 10 times at night. It's very easy to reach for the anticholinergics and say, job done. But actually, is this a woman who has overflow? Also, we need to take the time to think about reversible causes. We're all taught as medical students about the impact of obstetrics and pelvic floor trauma on urinary incontinence, and we cannot turn back the clock. So we can't undeliver these women. They've had their obstetric trauma. But actually, there's an awful lot of reversible issues that we can deal with. So are they drinking caffeine? A lot of women will say, no, I don't drink coffee, but they will drink tea, they'll drink hot chocolate, they'll drink cola. They will have diabetes, and they will tell me proudly they've stopped drinking normal Coca-Cola or Pepsi and now drink diet. But actually, diet has often more coffee in it, or caffeine rather, and it has aspartame and flavorings and artificial sweeteners, which are toxic to the bladder. So diet drinks actually are just as bad. And in fact, any sort of fizzy drink is a bladder irritant. And smoking, depending on the population we're in the UK, we're working very hard to reduce smoking, and I think we're getting there to a very minor degree, but in a lot of other countries, smoking among young women is on the increase. And again, our patients will turn and decide if they leak, they limit fluid. As limiting their fluid, they increase their urine osmolality and concentration, and this in return becomes a further bladder irritant. So we need to ask about how much they drink and what they're drinking. And this often will actually give us part of our management plan. Again, with the pandemic, we've all got very used to telephone consultations, but actually, as doctors, we all know that we have to put a hand on our patients, and it's not unusual to miss something very obvious because we haven't examined our patient. And the first core part of examination in urinary assessment, is really to exclude retention. It doesn't happen very often, but actually a lot of women, particularly as they get older, and if they develop a comorbidity such as arthritis or obesity and they can't get to the toilet in time, the effects of prolonged labour and neuropathies as a result of prolonged labour, then particularly pudendal neuropathies, over the years, they can't adapt and they will develop retention. And this is very easy, whatever your setting, examine your patient. If you don't have access to ultrasound, simply ask them to void and do a residual catheterization and measure their volumes. Look at women's pelvic floor. Our trainees forever tell me, yes, this woman is doing pelvic floor exercises. And my question to them is, how do you know? Have you examined her pelvic floor? Have you asked her to contract? So make sure this woman can contract her pelvic floor and make sure it's an effective contraction, because she may not have seen a pelvic floor physiotherapist or nurse who can actually instruct her properly. Urine dipstick, again, very basic, but ensure that we're not looking at long-term bacteriuria or acute UTIs. And treat these recurrent symptoms. Symptom scoring is really important. And it's very important if you have to enter your database, your information on the database. But in actual fact, it doesn't change your management. Because whether a woman scores high or low, I'm not going to turn around and tell her that you don't score high enough for treatment. If she has an impact on her life, she needs treatment. But it's actually quite good for monitoring progress, as are quality of life questionnaires. Now, bladder quest diaries, again, are another thing we tend to underestimate. Our physiotherapy colleagues use them really, really well. But actually, bladder diaries are very, very good to actually get your patient to focus on what she's drinking, how much she's drinking, and the impact changing her lifestyle and changing her habits has on her bladder function. The differential is very easy. You've got a normal bladder on the left here. You've got a bladder that has got overactive, detrusor overactivity in the middle. And on the other side, you've got a bladder whereby the patient has stress incontinence. In reality, though, life isn't like that. Now, I am a skeptic in terms of research. I've published loads of articles, but I remain a skeptic because I know that every one of us who does some research, it's biased for that population, it's biased for that setting, it's biased for the question we're asking and the answers we want. And nobody publishes negative results. So in urogynecology, there's a huge focus on stress incontinence because we're all actually surgeons and we all love operating, and that's fair enough. But in actual fact, most women, I feel, have mixed symptoms. And I think it's actually very important to treat the urge symptoms first, because if we go straight to surgical management and don't address and educate women on underlying factors that can contribute to or cause urge incontinence, in the long term, we're actually not curing them. We're not making them better, and then we lose confidence. And the patient's confidence in us as an honest, open, and well communicating practitioner is actually the most important part of any therapy. If our patients don't trust us, nothing is going to work. So again, back to what we learn as medical students, sometimes we forget what's normality, and we need to educate patients as to what's normality. So with aging, renal concentration reduces. We get a reduction in diurnal variation, and particular release of ADH changes as time goes on. So in the older we get, the more our diurnal variation of micturition flattens throughout 24 hours. And add into that medical comorbidities such as diabetes, neurological disorders, and drugs. And it's very easy to see how the patterns of micturition change. We have patients, particularly in the older population, many of whom have peripheral edema. They've got poor venous compliance, they've got vasodilators, they lie down, then their cardiac return increases, so the cardiac output increases. This gives a temporary increase in renal perfusion, and they develop nocturia. So very simple things. So I think, again, as surgeons, gynecologists, we forget our basic medicine, and an awful lot of urogynecology is medicine, not surgery. So simple things. So telling a patient who has heart failure to actually go and lie down in the afternoon or throughout the day regularly to get rid of the peripheral edema will help reduce the impact of lying in bed at night. As I said, I think it's essential for all types of urinary incontinence to address lifestyle factors and non-pharmacological issues first. And this is what takes time with your patients. Looking at lifestyle issues, looking at diet, in particular weight and constipation. And again, obesity is something that is traveling like a pandemic throughout the world. And I'm sure a country as vast as India, the incidence will vary from area to area and population to population, but it is still on the increase. One thing that really annoys me is when people refer only to pelvic floor exercises, because I think this is not just pelvic floor exercises, it's pelvic floor re-education. And also educating patients into expectations and what are realistic expectations, and emphasizing the fact that managing urinary incontinence is often like managing any other chronic condition such as asthma, COPD, diabetes, hypertension. It's a lifelong management strategy and not simply a one-stop cure. So as I said, physiotherapy is not just pelvic floor exercises, it's bladder drill, it's voiding technique. How many of us ask our patients how they sit on the toilet? So a lot of women will not sit on a toilet that isn't their toilet because they think they're going to get an infection, and they try to hover over a toilet and don't actually relax their pelvic floor in order to empty it properly. Bowel management, how often do you go? What's the stool consistency? Are you fully emptying your bowel? And physiotherapy is not just for Paris women who've had children. So in my pediatric clinic, I do adolescent gynecology pediatrics. And I see an awful lot of children with urinary incontinence where actually they have got into bad dietary and bladder habits. So physiotherapy is very much a global issue. I think expert physiotherapists are a core part of the wider team if you have the resources, but I think understanding the role of physiotherapy as a doctor can be really useful. And I think the most destructive thing we can do is just give a leaflet, because we have no idea whether the patient is actually contracting their pelvic floor or not. So I sit and I tell patients how to do their pelvic floor exercises. And in the interest of time, I'm not going to read this through, but this is a very interesting exercise to do if you're sitting and face to face with a mixed audience, because everybody in the room does it at the same time. And when I talk to my patients about their pelvic floor, the nurses beside me, I can tell by the expression on their face that they are all doing their pelvic floor exercises at the same time. I think there's a lot of misconceptions about pelvic floor exercises. And despite doing this for 25 years, I recently had a patient who told me she had to stop doing them. And when I asked her why she had to stop doing them, she said her arthritis had got bad and she couldn't lie on the floor. And she actually thought you had to lie down on the floor to do pelvic floor exercises. And that was a huge awakening for me in my communication skills, because I thought I had gone through things really thoroughly with her, but clearly I hadn't. So again, as you can see, that there is a particular regime to pelvic floor exercises. It's very much as if you were doing any other sort of training. If you are running for a marathon, training for any sport, you're going to train muscles in a particular regime, and it's the same with the pelvic floor. Obesity. Unless we address some of this, we're not going to ever get rid of incontinence. So the way forward here is, I must say, it's an area I'm very skeptical. I think dietitian management can be helpful, but only for a very motivated patient group. Increasingly in the UK and in well-resourced areas, we are going to be sending more and more people for bariatric surgery. And this is because of the general, and not urogynecological, but the general health impact. Most likely reduction of diabetes, which is hugely rampant in the UK at the moment. So bariatric surgery, where it is available, is often part of the package of what we do. In terms of management, you have got to really get patients to get rid of bladder irritants and address their diet. And in terms of drinking water, it's not just water, it is a volume of water. And in fact, I actually recommend tap water where it's available, but where tap water isn't safe, it may be bottled water. I do this as my baseline management for both overactive bladder and for stress urinary incontinence, and go through a comprehensive range of getting rid of irritants, and also talking to patients about what their expectations might be. So moving on to pharmacology. So the aim of pharmacology really is to reduce the symptoms, mainly reduce urgency and frequency. So this will lead to an increased bladder capacity, and that in itself will help decrease nocturia and incontinence episodes. I was taught by some very experienced urogynecologists who back in the day were wonderful believers in bladder stretching and hydrodistension, and I haven't done that as a treatment for a long time. And talking to our urology colleagues, it's not something we do very often anymore, even for small capacity bladder. Everybody I see gets started on vaginal estrogen, and I think this is very much my personal holistic approach to women's health. It does improve in postmenopausal women epithelial quality and treat urethritis and UTIs. It reduces the impact of UTIs, and it's probably the one thing that's missing in chronic recurrent UTI management. It helps improve sexual function. We don't talk about it a lot with our patients, but it is a huge part of everybody's life, so why not help? It does facilitate healing, so a lot of our patients may also have prolapse and may be going to have surgery, so improving epithelial quality in the vagina will help with post-operative healing. And it will avoid ulceration and treat ulceration if pessars are used. And the other thing that has to be part of a regime is regular stool softeners. So, you know, your diets are probably more healthy. People change, and we're all moving to more modern and processed diets. So constipation is again on the increase everywhere as we get more sedentary and often as we get more affluent. And a lot of my patients will use laxatives and stool softeners only if they develop constipation, and won't use it prophylactically, and particularly in the elderly population, that's important. So in terms of treating overactive bladder, there's two regimes. We're either approaching the traditional parasympathetic pathway using anticholinergics, in particular antimuscarinics, or the more modern ones, and at the moment mirabegron is the only one available, which is one of the adrenergic stimulators. And either way, we either inhibit the contractions of the detrusor muscle, or we increase relaxation of the detrusor muscle. And lots of people will say, but if your patient has stress incontinence, will this help? Well, actually, if you're managing somebody on history and examination, this is worth doing, because for some women whose symptom is stress incontinence, what happens when they cough and sneeze is that they have an inappropriate detrusor contraction. So actually, by managing their detrusor contraction, you will often improve their stress incontinence. So our first line management would always be go for pharmacology unless it's contraindicated. Talked about this. They do work. They reduce micturitions. They reduce incontinence episodes. There's no doubt about that. And if there's an improved side effect profile with the newer ones, well, then women will stay on the drug, and persistence data proves this. Challenging cases, well, challenging cases are those where there's non-responders, where there's a mixed picture of lots of different factors, and where there's a coexisting problem such as a prolapse. And that, I think, is probably one of the most challenging ones, because we have a temptation to examine our patient, find a prolapse, go, yes, I'm a surgeon, this is something I can operate on. But actually, forget to wind back. And the patient's first symptom is often incontinence, not prolapse. So unless they have a significant prolapse, operating in their prolapse doesn't cure their incontinence, it often makes it worse, and the patient loses faith. So the patients who are non-responders, well, we often use urodynamics here, and not necessarily full urodynamics, maybe just doing flows and residuals if we think there might be voiding problems that we haven't identified. Double therapy, if it's tolerated, is very helpful. And then we might move on to intravesical Botox, which is very, very good. Very easy in that it can be done in the outpatient setting, just using Instilla gel and not needing anesthetics. So for the frail elderly, it's very good. Patients will need, the majority of them, repeated treatments. The biggest potential side effect that causes problems is retention. So if your patient has voiding problems, these women need to be talked to about the need for intermittent self-catheterization, or in some cases indwelling. And specific patient groups like having it. Neuromodulation is extremely popular, extremely trendy, but extremely expensive. And we have a reasonably well-resourced care economy. But locally, our population is a poor population, and we have access in our hospital to neuromodulation. It is available for fecal incontinence. So if we have patients who have both fecal and urinary incontinence, we can often get it done through colorectal surgery, but not for everybody. So as I said, mixed picture, treat the overactive component. We do have MDT discussions, and that's because we have MDTs and they're easily available to us. We had the discussion as to which is the predominant symptom. Things change. Certainly when we were using tapes 10, 15 years ago, because tapes themselves were proven to cause a lot of overactive symptoms. We always went for overactive symptom treatment now. With the modern urethral bulking systems, we tend to use that equally. But we have to look at the side effects, we have to look at recurrence of other issues, and we have to consider voiding difficulties and how that patient can manage them. If there's prolapse, particularly if it's significant prolapse, it will have to be treated. And this is where telling the patient what you're doing is really important. It is important to tell this woman, actually, after your prolapse surgery, this might improve your incontinence, it might not. So if your patient has got a huge cystocele, when she goes to bed at night, that cystocele will reduce and she'll have nocturia. If you repair her cystocele, that will improve her nocturia, but actually she may end up with a drain pipe urethra and end up with loss of sphincter control or stress incontinence that needs treatment later. So counseling patients as to what to expect is important. And for this group of women, I often ask them to use a pessary as a temporary measure because it mimics the effect of surgery, and then they know where they're heading. So we do have a local MDT. You know, MDTs have become very much part of guidelines and very much a trendy thing to have. But actually, MDTs are what good doctors have been doing for generations. So when I was a junior doctor, I never heard of an MDT. But I went and knocked on the boss's door, and sometimes he would say, refer this patient to an elderly care physician because their drugs need sorting. So what an MDT is doing is simply bringing together what our teachers have been doing for generations and making it a bit more feasible. So we attend our MDT as urogynecologists. We have nurse practitioners. We have a urologist who comes and talks with us. We have a pelvic floor physiotherapist, an elderly care physician. Our colorectal colleagues don't join our MDT regularly, but we do have access to them. And similarly, we are very fortunate that we have very interested and engaged radiologists who will come and show us images if we need. So surgery, right, as I said, we use Botox for overactive bladder, do it under local, patients are taught how to self-catheterize, and they may need repeated treatments. I've got women who, particularly neuropaths, who are having their 13th, 14th, 20th treatment. I don't think I've ever sent somebody for neuromodulation without trying Botox first, but availability and cost is a major limiter for this. And I would say 95, 99% of our patients we manage without it. Urinary stress incontinence, well, as we all know, there's been huge changes here in recent years because we, with the issues regarding mesh surgery, so we don't use mesh for incontinence anymore. We give patients decision-making guides, but I have to say my patients still turn around to me and say, what do you think, doctor? That's why I'm coming to you. I'm coming to you for an answer rather than reading a piece of paper. Urethral bulking is the main thing we are doing at the moment, and that's twofold. First of all, I think patients like it. It's very easy in the outpatient setting. It's safe. We here in our hospital and in the UK, because of the pandemic, inpatient elective operating has went to a complete halt. So we were able to continue with local anaesthetic lists when we couldn't do inpatient lists. So the alternatives of copper suspension and autologous slings are certainly in our treatment options. And I suspect and envisage that down the line, we will be increasing the number of those we do again. Personally, I'm very happy to see the return of copper suspension. It was the first operation I learned to do in urogynecology. Then it went out of fashion, and it's nice to see something we've used for a long time come back into fashion. Pelvic trainers and supports are very important, and your physiotherapist can talk to patients about these, and they can buy these on the internet. But when a woman comes to me and said, I've bought a device, I always ask, has she seen a physiotherapist? Does she know how to use it properly? Indwelling catheters are sometimes necessary for a small few patients. If you have a patient who isn't fit for surgery, who isn't fit for medical management because of comorbidities, or they don't work, and there's no other option, and they are incontinent and getting skin conditions, an indwelling catheter may be necessary. Particularly neuropaths, we have a lot of those where they have indwelling catheters, and we try and encourage them to self-manage with a flip flow valve by day so they don't have to go out with a bag, and then use a drainage bag by night. And a lot of my women are reluctant to try a catheter because they don't want to have a bag, because that's their image. And if we say to them, actually, you can have a valve, you're fine. And finally, and this is my last slide, you'll be happy to know, back to the realism and communication with your patient. The picture on the left is a wonderful waterfall in the middle of South America I trekked to about 10 years ago. That's what our patients come to us with. On the right is a trickle of water in another waterfall I visited. And I think it's important to tell our patients that sometimes we can cure them, but quite often what we're looking for is improvement with lifelong management. So thank you very much for listening.
Thanks, Professor Mahoney. for that wonderful scientific deliberation. It was really exhaustive, extensive, and very informative. You have rightly emphasized the importance of history taking, which is very important, which all of us should practice very nicely in our day-to-day practice, and importance of examination. You've rightly said the urinary incontinence most of the times have mixed symptoms, stress, urge, and as well as overactive bladder. And definitely, you've told the importance of diet, pokes, which we never knew earlier. We should be very communicating with our patients. We should try to extract as much history as we can. And definitely, treatment of our incontinence is mostly medical, not surgical. And it should be treated on the lifelong basis as a chronic procedure, not on the spot. And definitely, we have to train our patients to do right pelvic floor exercises together with the help of a physiotherapist. And definitely, wherever the surgery is required, we should offer them. Thanks again, Professor Mahoney. We all have really gained from your wide and exhaustive scientific deliberation. It was really fruitful to hear you.
Thank you, Dr. Finley, for your wonderful talk. I think still the role of history taking and examination is quite in the clinical things. And by this, we can make out many things. And even in these cases, like I think so, for going on medical therapy or surgical therapy, most of the things can be managed by the lifestyle modification, weight reduction, treating the UTI. These are the small things we never thought of, reducing the volume of water. And like this drink, we are thinking this, we use this drink so many times. So many things, really, it is very useful. And thank you so much for a wonderful talk. And thank you, Lakshmi ji, for giving this opportunity to chair the session. Thank you so much. Thank you, Mala, for chairing this.
Thanks, Dr. Jaiswal, for co-chairing with me, and thanks, Dr. Lakshmi, to give us an opportunity.
Thank you so much. I think.
Thank you so much. Thank you, chairpersons. Thank you, Dr. Jaiswal, Dr. Mala Srivastav, and the wonderful, clear, very lucid talk by Professor Mahogany. We move on to another talk on recurrent UTIs and management, for which I have two chairpersons. We have Dr. Tabassum. Can I have CV of Dr. Tabassum, please? Yeah, Dr. Tabassum is a minimal SS surgery diploma, also has diploma in reproductive medicine, is director of the Jubesta Hospital, Raipur, secretary of Raipur Obs-Gynae Society, president-elect Raipur Obs-Gynae Society, and an active FOXY member. Welcome, Dr. Tabassum. And we have another very special, in fact, I would like to say, so because otherwise we would never have known Dr. Anil Shrikhande. Today we had a chance to have him, to host him on this platform. Dr. Anil, who's consultant urologist, andrologist, Shrikhande Hospital Research Center, Nagpur. So welcome, Dr. Shrikhande, sir. And over to the chairperson.
To Dr. Lakshmi. Thanks to Dr. Lakshmi for introducing you. So, thank you so much. We also knew.
Yeah, so welcome Dr. Shrikhande and Dr. Tabassum, and please take over from here. So and to invite our speaker.
Thank you very much, ma'am. It's my honor today to be part of this prestigious event, the webinar, which is being conducted by you. It's thank you, Dr. Lakshmi Shrikhande, ma'am. Today, I would like to invite our first speaker, Dr. Yi Ling Chan. She is a consultant in obstetrics and urogynecology, Women's Service, Calderdale and Huddersfield NHS Foundation Trust, United Kingdom. Secretary and pelvic floor multidisciplinary team coordinator. She has got many qualifications. She is MBBS, MRCOG, FRCOG, and she is registered to General Medical Council. and she's also registered to Royal College of Obstetricians and Gynecologists. She is a national and international member of International Urogynecological Consultation Committee, BSUG Audit and Database Committee, European Urogynecological Association member, International Urogynecologist Association member, British Society of Gynecological Endoscopy member, European Society of Gynecological Endoscopy member, UK Continent Society member, and she has got many feathers in her hat in terms of awards, like Trust-wide Award competition in 2021, and she has received Clinical Excellence Award in 2019, British Society of Urogynecology Unit Accreditation in 2017, Green Flag Award, University of Leeds in 2016 for excellence in medical field. She has got Outstanding Chinese Teacher Award in 2014 and Clinical Excellence Award in 2012. And she has got many research, her research portfolio is vast, and she has received many awards and many publications. And over to you, ma'am. Welcome you to this webinar today.
You have to unmute. Dr. Yi, please unmute. Yeah.
Okay. Thank you, Chairperson, for the kind introduction. And I would like to thank Dr. Anapa and the organizing committee for kindly inviting me to this webinar. It's a privilege to be here today. Before I start, I'd just like to say to Professor Mohani, I was in awe listening to the talk. I think there was quite a lot of information in there, that a lot of take-home messages. I have to say, you know, what we haven't done very well in urogynecology is embracing women's health physiotherapists' input in the management of women with pelvic floor problem in general, not just urinary incontinence or prolapse. And you will see some, what do you call, same theme when I give my talk today. So I was asked to talk about recurrent urinary tract infection in women, okay? You can see my slide, I hope.
Yes, we can see your slides. Perfect.
Thank
we can
you.
hear you. Yeah, please go ahead.
Thank you.
Yeah.
So I am based in Halifax, a few thousand miles from India. I have no disclosures. So urinary tract infection is common. It is more common in female due to shorter urethra. Up to 50% of women report urinary infections in their lifetime. About 20 to 30% of women have recurrence. A cohort study showed about 2.6 incident recurrent infection per person per year. The pathogenesis is usually due to ascending infection. It can be, the risk is higher in women with structural or functional problem or both. Bowel contamination is the most common cause. It can also be provoked by sexual intercourse, and the risk is also higher in patients with diverticuli and stones. The common pathogens are E. coli, Staph aureus, Proteus, and coliform. What are the risk factors? The risk factors include diabetes, immunosuppression, having new partners, urinary tract abnormalities, voiding problem, having an indwelling catheter, and also urinary incontinence. The typical symptoms of UTI are dysuria, frequency, suprapubic tenderness, urgency, polyuria, and hematuria. In the elderly population, the presentation may be less typical. Some may present with delirium and confusion. Presence of fever differentiates between inflammation and infection. I hope you can see the whole slide. Can you see the whole slide?
Yeah, we can see your whole slide. Yeah.
Yeah, so urinalysis. We all do urinalysis when patient comes to us with urinary infection symptoms. The sample should ideally be a clean catch midstream early morning sample. It is very important that we store the dipstick according to the manufacturer's instruction. If the dipsticks are exposed to air for a long period of time, the false positive rate is higher. We shouldn't use dipsticks for asymptomatic women or catheterized patients. The presence of nitrites and leukocytes in combination gives a higher predictive value of UTI than leukocytes alone. And nitrites are nitrate breakdown by the bacteria. If you see leukocytes alone on the dipstick, it can be because of vaginal contamination. When there is any suspicion of when the dipsticks are positive, we should send a sample, as always, to for MSU culture and sensitivity. Test of cure is not recommended. What are the red flag symptoms? I'm not sure about the protocol in India. In the UK, when someone has red flag symptom, when you suspect bladder cancer, we have got what we call the fast track referral pathway or 2-week wait referral. So women above the age of 45 and above with unexplained visible hematuria or frank hematuria without UTI should be referred under the fast track route to rule out bladder cancer. Women above 45 with hematuria but presence of infection should be reviewed after treating infection. If they have persistent hematuria despite clearing the infection, they should be referred as a fast track to the urology department. And women above 60 and over with unexplained, non-visible, meaning microscopic hematuria, should also be referred under the fast track route. The cutoff for visible hematuria used to be 50, I believe. So initial management and prevention of UTI, we expect the general practitioner, the primary care team to look after the patient without referring to the hospital specialist. So hydration, hygiene advice, wiping from front to back, simple analgesia like paracetamol and NSAIDs, and the antibiotics should be based on local guidance. In the UK, in general, the first line treatments are trimethoprim and nitrofurantoin, and the second line treatments, amoxicillin and cefalexin. The prescribing algorithm may vary from center to center. Pyelonephritis or kidney infections, it tends to follow lower urinary tract infections. It's more common in the elderly. The symptoms are rigor, loin pain, feeling unwell, nausea. The routine investigations are urinalysis and MSU, full blood count, CRP, imaging such as ultrasound and or CT scan to rule out urinary tract pathologies. And the treatments are simple. You treat the symptoms and you give the antibiotic based on local guidelines as far as hydration. So how do we define recurrent lower urinary tract infections? The criteria is 2 confirmed UTIs in 6 months and 3 confirmed UTIs in 12 months. So assessment, going back to the basic principle, like what Professor Mahoney said, examine the patient, put your hands on the patient, rule out the obvious. Pelvic mass, for example, atrophic vaginitis, treat these accordingly. We do urinalysis, we send MSU for culture, we do imaging, either ultrasound or CT scan, depending on the circumstances, and also cystoscopy to rule out CIS, for example, carcinoma in situ, stone, or in the urogynecology field, maybe mesh extrusion into the bladder. Lifestyle measures, do the simple things first, apply what we call the holistic approach. Always works. Hygiene, treat any constipation and diarrhea. Patients who have postcoital UTI, we advise pre and postcoital voiding, and we should also optimize diabetes control. Atrophy, this is a big thing. I think in general, healthcare professionals and public are more aware of the value of vaginal estrogen and HRT since 3 or 4 years ago. Atrophic vaginitis, genital urinary atrophy, or currently we call this genital urinary syndrome or menopause, is very common. I think many women with recurrent UTIs did not receive the appropriate vaginal estrogen for years and years. Things are getting better in the UK. It's believed that the low estrogen environment causes reduction in the lactobacilli species in the vaginal microbiome. Because of the reduction in the good bacteria, the harmful bacteria such as E. coli become more rampant in the vagina microbiome. This leads to the risk of UTI in postmenopausal and perimenopausal women with atrophy. This can be very easily corrected by using topical vaginal estrogen. I will go into detail in a moment. This is, I don't want you to zoom in to have a look using a microscope. This is just to show you, I'm sure you have your own algorithm in India. So this is the National Institute for Clinical and Care Excellence, or we call NICE guidance, algorithm for management of recurrent urinary tract infection. I will share with you the relevant parts of this algorithm. So, always apply holistic approach, lifestyle measure, wiping from front to back, hydration. After doing all the simple measures, we can do a few things. One is to prescribe antibiotic, first line and second line, but never forget that there are also non-antibiotic and non-pharmacological treatments which may be effective and beneficial for the patients. You will see, is this clear enough for you?
Yeah, this is clear.
Yeah.
You can see.
Yeah, so you can see antibiotics are an okay option, but you also have vaginal estrogen, methenamine, vaccine, cranberry, D-mannose. These are all appropriate options for recurrent urinary tract infections. If the above measures are not successful, then the patient can go on either continuous prophylactic antibiotics for 3 to 6 months, or single dose post-coital, for example, post-coital prophylaxis of the same first line, second line antibiotics, or patient can opt for self-start antibiotics, short courses, 3 to 5 days, using the same antibiotic options. It all depends on what, your local guidance, okay? So these are the national guidance, antibiotic based on national guidance. In the elderly population, we need to be aware that women above the age of 45, we need to interpret the urine dipstick very carefully. They tend to have higher false positive rate. They are also more likely to present with atypical symptoms such as delirium and dementia. Asymptomatic bacteriuria is present in up to 19% of elderly populations and 15 to 50% of elderly individuals in long-term care. We should not treat asymptomatic bacteriuria, and elderly institutionalized patients frequently receive unnecessary antibiotics despite the lack of evidence of clinical benefits. So follow up, once you have done the initial treatment, you have tried non-pharmacological and non-antibiotic therapy. If the patient continue to have problem, you start the patient on long-term low-dose antibiotics or various other options. What do you do with these patients? You should do a follow-up around 3 to 6 months later. Always consider withdrawal of the treatment. Sometimes the long-term antibiotics or methenamine, which I'm going to go through in detail, break the infection cycle, allow the bladder to recover. So some patients may be all right coming off the antibiotic regime. So if they are symptom-free, you can stop the treatment. in 3 to 6 months. However, we need to inform the patient that recurrence is possible. They may need to go back on the same regime as long as they don't develop any antibiotic resistance. However, one recurrence is not the reason to go back on the long-term antibiotic regime. We just need to give some more time to see whether there is any pattern to their symptoms. So if the regime failed to work, then the patient should be referred to the specialist for further investigation and to be considered for more invasive treatment, such as intravesical glycosaminoglycan layer therapies, intravesical antibiotics, or even surgery. Decision 8. In the UK, we have published quite a number of decision 8s for treating a variety of clinical conditions, including incontinence, prolapse, mesh complication treatment. We also have decision 8 for recurrent urinary tract infections, which explain the decision 8 is basically a booklet or leaflet which explain to patient what they can do, what are the options available for managing the recurrent urinary tract infection, self-care options, estrogen, variety of antibiotic and non-antibiotic options. So the decision 8s are evidence-based. One of the reference was based on Albert et al.'s Cochrane database systematic review. The database review showed that the risk ratio for UTI with antibiotic prophylaxis compared to placebo was 0.15. Zhong et al. Showed that in the RCT, they showed that recurrent UTI, there was no statistically significant difference in the number of women who had at least one recurrent UTI in continuous antibiotic group compared with the intermittent antibiotic group. Perrotta did a systematic review, and they showed the efficacy of estrogen cream in comparison to placebo. The risk ratio was 0.25. Was 0.25, which is great. So I'm going to spend some time talking about low-dose vaginal estrogen. So low-dose vaginal estrogen, when you talk about estrogen to women in the past, in the past, I'm talking about 3-4 years ago, as soon as you mention the word estrogen, the immediate response you get from patient, from healthcare professional, people relate vaginal estrogen and any form of HRT to breast cancer. So some patients can get very upset, when you mention estrogen, you emphasize why they need. And some patient may come back to say, okay, since you have started estrogen, I've got this breast pain, I've got, a headache, bloating, feel unwell, and so forth. The public perception of vaginal estrogen was colored by a lot of myths and misunderstanding. So in the UK, the commonly available vaginal estrogens are Vegifem, Ovastin, Gynex cream. Invalgase is also a very low dose, safe product, but not that widely available. It's not that well known in the UK. Vaginal estrogen Vegifem, for example, is a very, very low dose product. Each pessary is 10 microgram. So when patients come to, I'm not sure about the India, experience. When patients come to see us, after you advise them to use vaginal estrogen, quite often people used to come back to say, I haven't started it because it's a HRT. I don't want to get breast cancer. But if you look at the product, Vegifem is a very, very low dose product. Each pessary is 10 microgram. So the prescription that we are giving to patient is 1 pessary every night for 2 weeks, and then twice a week, long term. I say long term to the patient. I don't say use a course, because a course means a month or so, maximum 6 months. By the end of 6 weeks, sorry, 6 weeks, not 6 months. By the end of 6 weeks, the patient start to gain from the therapy. When you stop the vaginal estrogen, the atrophic change will come back. So it's not something that we should advise patients to use on an intermittent basis or a short course basis. It should be done long term. If you follow the strict prescribing instruction, in a year, the amount of estrogen a person is exposed to is 1.14 milligram, which is similar to 1 HRT tablet going into the vagina in a year. So this cannot, I always say to the patient, if you put this into calculation, it's the same as 1 HRT tablet in the vagina. This is the amount you're exposed to. So it cannot cause you breast cancer, womb cancer. It cannot cause you clots in the lungs and legs and so forth. So the attitude towards estrogen has improved in the UK because we understand the product more. I would like to share this with you. Dr. Louise Newson, those who have worked in the UK may be aware that she is a GP with menopause expertise. She runs the biggest menopause clinic in the UK, and she started her service sometime in 2018. Because of a campaign, the public perception on HRT and menopause has improved, and the healthcare professionals' attitude towards HRT has also improved over the years. So because of a campaign, now the government, the UK government, is doing consultation to consider putting vaginal estrogen, allowing the vaginal estrogen to be given over the counter. So things are changing. For women who have postcoital urinary tract infection, who also have sexual problem due to vaginal atrophy, we generally advise the patient to use vaginal estrogen, vaginal moisturizers such as Riplens, Hyalofem, Yes, and so forth. And during sexual intercourse, we advise patients to use lubricants such as silk, Durex Play, Jur, or even something available in the kitchen. But what we say to the patient is do not use KY jelly, because KY jelly can crystallize and generally, it's sticky and crystallizes, which can be counterproductive. So going back to the algorithm, the UTI algorithm, you will remember seeing methenamine hippurate on the non-antibiotic section of the initial management. Methenamine is not an antibiotic. It has got antibacterial or antiseptic properties. When it's metabolized, the chemical left in the bladder provides an antiseptic effect. So it is a useful adjunct to recurrent UTI prevention. It is maybe ineffective in patients with neuropathic bladder or abnormal urinary tract. It's not suitable in women with gout, severe renal and liver impairment, but it's generally quite safe to use. The benefit of having this instead of long-term antibiotics is methenamine doesn't cause any antibiotic resistant issue, because we do not use methenamine to treat infection, so you will never have antibiotic or any resistant issue as such. This has become more and more popular in the UK, and lots of people who used to be on long-term antibiotics are given methenamine instead. What about non-pharmacological options? No matter what you say to the patient, what decision aids or information you provide to the patient, patients do Google. I'm sure, in every continent, the patients and even healthcare professional Google and try to find non-medicated, alternative remedies to manage the urinary incontinence or recurrent incontinence. Cranberry juice is it useful? There was some evidence to say there is no benefit in taking, cranberry, but on the NICE guidance, cranberry has now become one of the recommended products for prevention and management of UTI. The optimal dose and duration of use is unclear. Apparently, capsules are better than juice. D-mannose is also one of the recommended remedies for prevention of urinary tract infection. It is a sugar, it's not a medicine. It's available in a powder or tablet form. One study showed that it is as good as nitrofurantoin in preventing recurrent UTI. So once a patient has gone through the initial treatment, have their preventative measures, if the symptoms remain troublesome, they can be referred to the urology department or urogynecology department where the service is available for invasive treatment. The invasive treatment include something like gag layer therapy, which repairs the damages of the glycosaminoglycan layer of the bladder. There are multiple regimes available in the UK. These include hyaluronic, Hyacist, and Cysistat. The gag layer therapy reduces recurrent UTI and it carries very little side effects. They are often administered by specialists. In our center, it's a nurse-led service. The clinician make the decision sometime in the MDT after consulting the multidisciplinary team, and the nurse deliver the service. Some products are also suitable for self-administration. If the patients are willing and is able to self-catheterize, we also allow the patient to do the treatment at home. Intravesical antibiotics, it is the most commonly used antibiotics are gentamicin and amikacin. It is only used or prescribed in specialist centers and has been anecdotally reported to be helpful for some patients. However, it can only be used with expert advice. We don't do this in our center. I'm not sure any of you have any experience doing intravesical antibiotics. Vaccines, again, theoretical. Vaccines are immunostimulants rather than true vaccines. It is prophylactic treatment. The prophylactic treatment with vaccines consists of a combination of inactivated uropathogenic bacteria and has been shown to reduce the incidence of recurrent UTIs. Availability is an issue in the UK. I'm not aware of this being used in our center, in our region, or in any region in the UK. It may be restricted to research settings only. Alternative medicine. Alternative medicines are unregulated. The evidence is lacking to support. So what I'm going to share with you, subsequently is not recommended by NICE guidance. Probiotics, dairy products, including yogurt and kimchi. The people who have done research on vaginal microbiome may promote the use of probiotics, but this is not appearing in the national guidance. How about the Indian home remedies? I had a quick look on internet, just like what patients do. We look at other remedies, all these are nice things that you can find in the kitchen. They're harmless in general. I know some of my non-medical friends swear by the value of turmeric, and some of my friends drink turmeric and they mix their own turmeric drink and have it every day. I'm sure you can educate me on this. How about yoga? Is yoga a good treatment for UTI? Yoga is very popular in the UK, originated from India, very, very popular in the UK and many parts of the world. Is yoga good for UTI? It's probably not curative. Some several yoga poses was said to be good in alleviating symptoms of menopause. These are the Cobra pose, Bhujangasana, bow pose, Dhanurasana, and the sun salutation, Surya Namaskar. Apologies for my pronunciation. So how about Chinese remedy? I remember as a child, we heard that the aunties and our grandparents promoting barley water. When anyone has UTI, they will get barley water to help them flush out the urine. People don't usually go to the doctor to get any medications. This is my recent finding. It looks like, there are two common remedies used by Chinese people. One is called 二仙片. 二仙片 or 二仙汤. Pian means, 二仙 means two fairies, and pian means tablet, and tang means decoction. So this product and the Sanjing Pian, which means 3 gold tablet. These are the two products that people can get from the traditional medicine shop. And these have been reviewed, published on Cochrane Library. There are a few 7 RCTs looking at the efficacy and adverse effects. The studies might be biased, but there was a high efficacy for acute UTI, and it showed to reduce recurrent UTI rate. No adverse effect were reported. And the authors also look at transplant register. They didn't see any adverse effect. So some food for thought. So these are the references. So before I end, I would like to give you 3 take-home messages. Number 1 is remember that the low-dose vaginal estrogen is effective in reducing recurrent urinary tract infections. And number 2, consider non-antibiotic treatments in recurrent UTI. Number 3, take holistic approach. Every patient is different. Consider using or developing patient decision aid for your local use. Namaste. Namaskar. I heard namaskar earlier today. Is namaste okay?
Yeah, Jyoti, just a minute. Yeah, thank you so much, Dr. Yeeling. It was a very, very informative talk. And as you said, namaste, COVID has taught us, everyone, that instead of handshake, we all have to go back and say namaste to each other. I had actually roped in Dr. Anil because I wanted to have the urologist perspective on UTI, but he has sent his apologies as he is busy with one emergency patient. And Dr. Yeeling, I must say that you have covered all the aspects, the pharmacological, the non-pharmacological, the traditional, and you have taken pains to go through the Indian things which we all practice and we Google. So it was a fantastic, comprehensive talk on urinary tract infection. And thank you so much for sparing your valuable time and sharing your ideas and your treatment schedule with all our delegates. Thank you.
Thank you.
Thank you, madam.
Thank you so much. Thank you, chairpersons, Dr. Tabassum and Dr. Lakshmi, the locum of Dr. Anil.
I am, it is urogynecology, so I can give.
So, and
we were waiting.
Yeah, we were waiting. Yeah. But, and thank you, Dr. Yili Chan. I mean, it was amazing. Absolutely amazing talk from you. We loved it. So moving on ahead, now is my pleasure to invite Dr. Sushma Verma, who's our national coordinator. And over to Dr. Sushma to do the further thing. We are halfway through and we are all waiting for this wonderful panel. Over to Dr. Sushma, please.
Good evening, everyone. Thank you, Dr. Jyoti, for giving me the opportunity. After this wonderful lectures on urinary incontinence and recurrent UTI, now we are going to start our panel discussion which is case-based on UTI and urinary incontinence. And it is moderated by our eminent faculties, Dr. Lakshmi Shikhande ma'am and Dr. Manjula Anappa ma'am. Lakshmi Shikhande ma'am does not need any introduction.
बस मेरा छोड़ दे, मंजुला को introduce कर.
And she is the big brain behind this webinar. Ma'am, I am telling your CV in very short. She is the chairperson elect ICOG, founder, pattern and president of ISOPOB Vidar chapter 2019-2021. And she is decorated with many awards and has many national and international publications. And our next moderator is Dr. Manjula Anappa. She is a very renowned consultant urologist with a special interest in urogynecology and pelvic floor disorders in University Hospital of North Midlands, Royal Stoke Hospital, UK. And then I would like to invite our esteemed panelist, Dr. Manoj Aglave sir. He is the consultant laparoscopic surgeon and infertility specialist in Siddhivinayak Hospital, Bhandara, and he is secretary of Bhandara Obstetric Society. And Dr. Saurabh Malia is the consultant PVS Hospital and Baby Memorial Hospital, Calicut, Kerala, and he is the chairperson FOXY Endoscopy Committee 2021 to 2024 and secretary of Calicut Obstetric Society 2020 onwards. And I would like to invite Dr. Jyoti Banglowala. She is the secretary of Indore Obstetric Society, and she has many presentations in various national and international conferences and recipient of prestigious Wonder Foxian Award and Corona Warrior Award from Collector. And our next panelist is Dr. Deepa Mukundar. She is consultant obs and gynae and endoscopic surgeon at Assured West Hospital, Trichy, and secretary Trichy Obs and Gynae Society from February 2020 to 2022. And she is the winner of many awards and executive member of Midlife Management Committee. And our next panelist is Dr. Anjali Kanhare. She is professor and head of Department of Obs and Gynae at CMCH Bhopal. And she is the president of Bhopal Obs and Gynae Society 2021 to 2022. And she is the recipient of Jagdeshwari Mishra Best Poster Presentation Award for 3 consecutive years. And she has various presentations in various conferences. And now I would like to invite Dr. Lakshmi Shikhande ma'am and Dr. Manjula ma'am to start the panel discussion.
Yeah, Manjula, floor is all
yours. Thank you, madam, for your kind introduction.
Yeah, Manjula, please start here.
Thank you very much for the introduction. Thanks a lot for my 2 consultant colleagues, especially my mentor, Professor O'Mahony. Her talk was so excellent. And whatever my practice is, all what she has taught me. And Professor Ealing, again, she is so good with physiotherapy. She's into the international urogynecology, pioneering the physiotherapy, how important it is. So between the 2, they have sent me 3 cases. So we're going to share the slides. We'll go through these cases and then see. Floor is open to the panelists to comment.
I will just share. Just a minute. I will share. Yeah. Manjula, can you see it?
Yeah.
Yeah, Manjula, sorry. Yeah. Start.
So the first case is a 34-year-old, so she's quite young, who has had a 1 normal delivery. She presented with complaints of prolapse symptoms and having incontinence when she's doing any high impact exercises like running, lifting things at gym. So examination, it shows it was stage 1 cystocele. That was at 20 when she was 29 years old. That was in the past. She was advised to do pelvic floor muscle training, but this time again she's come back with not only prolapse but also incontinence. Her BMI is very important, as Professor mentioned, that will have an impact. So it's 33, which we routinely do in our practice to check their BMI. Family history, nothing significant. She is non-smoker. She drinks little alcohol. And she actually herself works as a fitness instructor. So you can see that any impact exercises that she has to teach to her team, this is what is causing a problem with incontinence. So this time examination shows it's stage 2 prolapse, and there is also stage 2 cystocele and stage 1 uterine descent, but there's no rectocele. Otherwise, examination, nothing else is found, no mass. And the pelvic floor muscle strength is, we stage it into Oxford staging, which is Oxford 3. So relevant factors, what else we need to know in this history that would make difference in this treatment? And next question is, what are the treatment options here?
Yeah, Manoj, you would like to start? Yeah, Manoj.
Good evening, madam.
Yeah.
So she is a very young patient with 34 years of age, and she is having the first degree cystocele, and she was instructed with the pelvic training, and now symptoms are worse. And in this case, her BMI is 30. That means she is an obese patient, first of all. So, and there is no medical problem or no significant family history, or she don't have any history of smoking. So going to the history taking or relevant history, her cystocele is increased on serial examination, and there is a uterine prolapse and no rectocele, and bimanual examination is normal. So in this case, while history taking, we have to rule out the urinary tract infection first. So in that case, we have to ask for the any urinary frequency surgery or burning micturition. Then again, we have to rule out the history of any surgery in the past, like if there is any history of the anterior colporrhaphy or platonic surgery for our symptoms, and any relevant history related to the trauma during pregnancy or prolonged labor. So we have to rule out these things.
Yeah, thank you, Manoj. Manjula, you can add on history, and then treatment part, I would like Deepa to elaborate after you. Yeah, Manjula, please.
Yeah. Manoj, very well said. First thing is surgical history is important. We would like to know whether she has had any surgeries in the past, which will have an impact. BMI was very well addressed. Yes, so lifestyle modification is important for her to say that you need to reduce weight to reduce the incontinence, because looks like it's stress incontinence. And in terms of management, I don't think there's any need for surgery, because as you can see from Professor O'Mahony's slides, we offer surgery only if it is grade 3. So any conservative management, first thing is pelvic floor exercises, how to do it, and sometimes pessaries are helpful in these situations.
Manjula, just a minute. Yeah, Deepa, your take on the treatment aspect of this patient? Yeah.
Am I audible?
Yeah, you are audible.
Yeah, first of all, thank you to the organizers for having me on this esteemed panel with other esteemed guests, Dr. Lakshmi and Dr. Jyotsna. My take on this, yeah, she is a young lady, just para 1 with 1 child. So obviously conservative treatment is what I would definitely like to know, whether she likes to have another child. Is she planning for the next pregnancy, or she's going to stop with 1? And she herself being a gym instructor, or she's actually her job requires high intensity exercises. So I'd like to know what kind of quality of life issues that she's facing, whether it's disturbing to her job right now, or is it she's able to do away with this, or what is the quality of life issues that she's facing, so that I'll be able to make a decision to offer surgery or no surgery, or whatever. In any case, my first choice would be pelvic muscle training. She's just grade 3. I think she can step it up to grade 4 or grade 5 Oxford. Grade 4 or 5, she can try weighted cones. She can try, little more of pelvic floor strengthening exercises, and if she complains of urinary incontinence despite training, she can be put on medications like duloxetine for stress incontinence. That is something else I would like to try on this lady. Yeah.
Yes, Dr. Yealing, yeah, she has raised hand. Yeah, please.
Yeah, you have asked very relevant questions. This is a real case, and one of the many cases that we come across in England. So this is a 34-year-old Parawan who had a child. She had a quick labor. If you go back to the history, she was diagnosed with stage 1 sister cell at the age of 29. And then she just had a baby in recent years. She had more prolapse symptoms and more urinary problem. So there is some telltale sign in this history. Her occupation is, she's a fitness instructor. So it is very popular in the UK and other parts of the world for people to go to the gym, to do a variety of exercises for core strengthening, for cardiovascular fitness, flexibility, and so forth. So one exercise, called CrossFit has become very popular, and women go to the gym to do weightlifting, high impact exercises. So actually, if you go back to the history, she has been a fitness instructor for a few years. When I asked her questions, she said she used to lift 100 kilograms. So many times a week, 100 kilograms. She is not the only one. Unfortunately, we have a lot of people like that who ended up in a urogynecology clinic. So fitness instructor lifting 100 to 100 kilograms. So because of her prolapse and incontinence, she can no longer do 100. So she's doing 60 kilograms. I have also a client who lifted 120 kilograms, and patient with incontinence, prolapse, who get sent to physio, who chose not to see the physio for pelvic floor muscle training, they go to the gym instead. And as a result of what they're taught in the gym, build up your core strength and stability, we got more issues. So some of these people may go around to different center and they get a very quick assessment, go on the table for surgery. But what we don't know is, if you don't ask, you don't find this information. So I always say to our colleagues, your physio are your best friends. Your physio are not just people who tell patients to squeeze the pelvic floor. Physio is far more than just pelvic floor squeeze alone. They look at the whole patient and then look at these factors and they counsel the patient about all these potential risk factors that can potentially make their treatment completely unsuccessful. So this is just one of the many cases that we have come across.
Yeah, Manjula, you can sum up before we go to second case.
Yeah, as it's a young patient, it's important that we don't rush into surgical management. Lifestyle modification, working environment address is very important, and also whether she's completed a family or not. Obviously, it's progressed from grade 1 to grade 2, so she might not be doing the right thing. So it is important to address those issues.
Yeah, Jyotsna has raised hand. Yes, Jyotsna.
I have got a simple question. If she wants to have another baby, is there any role of elective cesarean section?
No, I always tell patients that it is not an indication having a prolapse because already the pelvic floor is stretched. So that's not going to prevent. So have the vaginal delivery, but emphasize on pelvic floor exercises post-delivery.
Thank you.
So now I am sharing my screen again and we want to go to the next case. Just a second. Yeah. Manjula, yeah.
So this is 75-year-old who has had 5 normal deliveries. Looks like she has more like an overactive picture, which is frequency, nocturia, urgency, urge incontinence. So her primary care practitioner started her on anticholinergic, which we call it as solifensine. She took it for 3 months. It's 1 tablet every day with not much effect. Past history, she has got hypertension and she is on medication for that, which is controlled. She's not keen for any surgical intervention. Her BMI is not too bad, which is good, which is 28. Examination shows that it's atrophic vagina, just lacks vaginal walls, but there's no significant prolapse. So the questions are, what other assessment or investigation we would like to do and what are the treatment options available for her?
Yeah, Anjali, would you like to answer? Yeah.
She's a 75-year-old lady, and definitely, as both the speakers have told us a number of times, history is very significant. We need to find out. It has been said that she's hypertensive, but diabetic, whether she's diabetic or not. And then definitely a new emphasis which I have received today is the bladder diary. We should probably ask her about the bladder diary, and we should evaluate that whether surgery will make changes and improve her quality of life. Then definitely we can offer her surgery, but we need to analyze her on these aspects also before we offer her the surgery. I would like to say I have two elderly ladies at my home. One is my mother-in-law and another one is my mother. And believe me, it is very trouble giving when you can't offer them with any such solution. It is very painful to come across their symptoms which change day in and day out. So Dr. Lakshmi, I would like to take this platform to thank specifically both your speakers for doing such a wonderful job in enlightening us on what we also many times don't try to find out from our patients.
Very true, Anjali. Yes, Jyotsna? I can see again your raised hand. Jyotsna? No.
Maybe that was from the past, sorry.
Yeah, it was okay. Yes, Manjula, you can take over. Yeah.
Yeah. Can I please invite Professor Mohani to just give her expert opinion on this case?
Thanks, Manjula. I think this is the sort of patient that we all know personally, because it's probably our mother, or older sisters, depending on how old we are. What we don't know here, as your colleague said, is what's her fluid intake output? What is she drinking? Is she drinking lots of tea? So I'd want to know more about her fluid function or her fluid balance. I'd also want to know a little bit more about her bowel function, because we don't know whether she's got constipation or not. So managing bowel function may help. I think some of her treatment, her symptoms may be due to atrophic vaginitis, so I would certainly be giving her some vaginal estrogen to begin with. And then if with optimizing bowel function, increasing non-caffeinated fluids and giving her some estrogen hasn't helped, then I would think about changing her onto mirabegron. A lot of GPs in the UK won't give mirabegron because they're concerned about hypertension as a relative contraindication. But if her renal function is normal, so if her eGFR is within the normal range, I would give her mirabegron. And if I thought she was particularly frail and concerned about it, I might put it at a reduced dose for the first month to see how well she tolerates it. And also, she says she doesn't want surgical intervention, but I wonder what she means by surgical intervention. So for a lot of patients, she might think, I don't want to have an operation, a general anaesthetic and a cut and a stay in hospital. If she knew what was entailed, if all of this treatment fails and she realised what was entailed with bladder Botox, she may be willing to have that, because that's more of it's an outpatient treatment as opposed to an inpatient operation. So I think there's a long ways to go with this patient and lots of potential for improvement.
Yes.
Thank you. Thanks.
Yeah.
Just want to mention what
Dr. Lakshmi, if I could ask Professor Mahogany a question.
Yes,
how long does it take for mirabegron to be showing the effects? Like, that is the first question. And what is her take on a combination pill of sulfasalazine and mirabegron?
Okay, so I think they're two very good questions. So for the first one, the manufacturers recommend 3 months before you can say it doesn't help. When I prescribe it, I tell patients that in that 3 months, I also want them to address the other issues. So if they've addressed fluid management, atrophy, and bowel function, and they have an improvement after 3 months, they might decide then if they can discontinue it and if the other factors take over. Dual therapy is used commonly. It depends on the 75-year-old. So if this is an active, yoga practicing, driving, going out 75-year-old, well then dual therapy is fine. If this is a frail, arthritic, compromised 75-year-old where I'm worried about, in particular, cholinergics and their impact on cerebral function because they cross the blood-brain barrier, I might be a little more cautious. So I think this is where individual approach is really important.
Okay.
Thank you. That's what.
Thank you so much.
Yeah, Manjula, you can sum up before we go to the last case. Yeah.
Important aspect is, one is the age factor. Please be aware. When you have to prescribe any anticholinergics, there is anticholinergic burden. As Professor mentioned, that there will be a lot of medications they are on, so don't put just solifenacin or any anticholinergics. The best bet is mirabegron is very good if the blood pressure is well controlled. And please counsel the patient that your lifestyle modification is important. You drink 2 or 3 cups of coffee and then you take 1 tablet every day. It is not going to work. So some commitment from patient side is very important. They can change to decaffeinated, and I say not more than 2 cups. Watch what you drink. Do not reduce the fluid intake. That's why bladder diary is important. And another aspect is bladder training. So try to extend your, instead of going within half an hour, make it 45 minutes and and then slowly build it up to 1 hour or 2 hours. So, and also please estrogenize is important, as Eling mentioned that you can use estrogen for long term. There was a question in the audience who asked, how long should I give the estrogen local application? It can be as long as it can be taken for lifelong. Thank you.
Yeah. So now we will go to our last case. Yes, Manjula? Yeah.
So this is a 65-year-old who has been having recurrent water infection, urine infection for last 1 year. She has already had 6 courses of antibiotics. Now she also says the prophylactic low-dose antibiotic has some effect, but not completely cures the problem. She has a history of fibromyalgia, which is a chronic pain all over the muscle and body area. She's non-smoker. She does drink alcohol 18 units a week. Examination shows atrophic vaginitis, very mild grade 1 cystocele. So the question is there any other history we would like to know in this case, and how do we go about management?
Yeah, Manoj, you would like to say? Yeah.
Yes, madam. She is a patient with the 65 years of the age with a history of the recurrent UTI, and she got benefited with some benefit with the use of antibiotic. And in the history taking, then we have to ask about the local hygiene, how she is maintaining. Then her about the sexual pattern, we also ask her. Then she is having the atrophic vaginitis. So in that case, sometimes there are the high chances of the getting infection. Then she is taking the alcohol. Then we have to ask about her fluid intake. They're taking is a proper fluid or not.
Yeah, Deepa, you want to add something to Manoj? Yeah, Deepa, you want to add something? What Manoj has already said, yeah.
Like to know whether this is a culture proven episodes of infection, whether it is what kind of culture positive reports that we have had. Is it a persistent or is it a recurrent or a relapse? So I'd like to also confirm that before I go ahead with the treatment strategy. And of course, whether she's had any surgery in the past for anything, like a descent or any urological procedures, and so whether she has had menopausal hormone therapy in the past, or these are the things I would like to ask her.
Anjali, you want to add something to this case? Yeah.
Yes, I would like to mention that we need to find out about her bladder habits also, whether she's not like holding the urine for a very long time, because many times recurrent UTI patients, they feel that their symptoms come back again and again, and they avoid. I'll not say that they don't like to use it, but psychologically they avoid going to and evacuating the bladder frequently. So that is what one thing I would like to ask about. And the second thing is probably there is some role of ultrasound to find out how much is the post-void urine, so that whether stresses of urine is one of the cause of UTI in such particular patient.
Yeah, to Anjali, I would like to say that in India, when woman is in a public place, we don't have the good hygienic
Absolutely.
toilets available when they are traveling in a bus or when they are out for
True, true.
shopping, and they really hold on for quite a long
Very
time.
long time.
So, I mean, your take on this also. Yes, Professor, I can see. Yeah, Professor Fidelma, yes. These are all questions for you.
Yeah, I think you're absolutely right. I think toilet training is an important thing. So yes, this woman might have retention. I think everything that Professor Yin has said here is important. You know, we need to look at what emptying is like here, and we need to look at atrophic vaginismus and clearly treat that. I'm also interested in her alcohol intake, because is she actually aware of her urge to micturate? And she's got fibromyalgia, and I wonder if there's any degree of neuropathy here. So I think a really good neurological assessment is very important to inform management in this woman.
Yes, yeah, I'm coming back to Dr. Yiling. Yeah, I know you have covered everything in your talk, but pertaining to this case, you can highlight some important practical points here. Yeah.
I am so impressed by the audience and the panelists' knowledge. I think you have already covered everything. You know, holistic approach, hands on the patient, rule out voiding problem. You know, frequency will have a bladder diary, treat atrophy. You know, rule out neurological problem, cut down on alcohol, and so forth. I think you have covered everything. Yeah, surgery, the common challenge that we have is when patients come to the clinic with this kind of presentation, quite often there is an expectation that we would treat by doing surgery. So a very common patient come to the clinic to say, I have got recurrent, I want a surgery for prolapse. But what is your main problem? Recurrent water infection. When you go deeper into the history, we quite often, find that surgery is not really appropriate. A stage 1 cystocele is unlikely to be causative for recurrent UTI, because you do need quite a significant drop to cause impaired voiding. Even if you find impaired voiding in this patient, we need to question ourselves whether the impaired voiding, which may cause UTI, is actually an existing problem or caused by a prolapse. Is probably unlikely to be due to a stage 1 cystocele. So correcting it surgically is probably not going to help. So, the highlight here is, there is atrophic vaginitis. Treat that in addition to every other measure that you put in. So I personally wouldn't do surgery unless you have exhausted everything and prolapse become, progressive. Then surgery might be considered, but definitely it's a no to the patient when they walk through the door.
Yeah, Manjula, you can conclude on this case, and you can take one question from the chat box also. Yes.
Very well said. Yes. Lifestyle modification, as we said, we keep emphasizing on it. It works both ways. We do, as a practitioners, we give them and tell them to do, but there should be some commitment from the patient perspective as well. Just to overall, summarize this whole session is my own personal story that my great-grandmother actually committed suicide, which I heard from my parents and from my grandmother, because she had this extensive bladder problems. They didn't know what it was. Every time when she used to pass urine, she would scream, it seems. But she was from village, so there was no access to any health care. But now, retrospectively, probably she must have had overflow incontinence or urinary tract infection that led to this tragedy. So it is important that we actually be very sensitive to this woman. Majority of those who had vaginal deliveries and even having a cesarean section is not a protective factor for not to have the pelvic floor problems. So my first thing I would say is that even having trained in India as well, we have come across obstetric trauma. We have come across fistula patients as well who do present with incontinence. So please be mindful. Examination and your history taking is so important. And also please refer them to an appropriate specialist who is trained to deal with the symptoms, especially with the fistula. Try not to operate if you have read and you've seen it, which is what happened during my post-graduation, that she has had a fistula repaired twice, but again, it was not successful. She was abandoned by her family because of the constant smell, and she didn't have any money to go anywhere. So please be mindful of where are the centers that can be referred, and please I request all my colleagues there to conduct all such workshops, including surgical workshops, now that of course COVID is slowly relaxing, so that we can train our relevant colleagues who can deal with these symptoms. The other thing about is with the environment in India, it is very hot, very humid, and wearing the sanitary towels or the pads because of their leaking can also precipitate the water infections. So again, increase the fluid intake is important. You can use barrier creams. Here we have got nappy rash creams, which are all helpful, that can be used in India as well, that if they're developing due to the leaking, their skin condition is bad, that can be given. And also, as both my speakers mentioned about history taking and examination, there will be some patients who will have coexisting lichen sclerosis. So please, that can also make it more worse with the urinary incontinence. So it is okay to use steroid cream. Please educate them how to use the steroid cream. When they use the steroid cream, and if it is cured, they shouldn't stop it. They still have to use, even when they are asymptomatic, the Betnovate or Dermavate cream at least 3 times a week, very little cream. Next thing is with regards to the PHC centers, because of the physiotherapy, we are talking so much. I think we need to educate our PHC team to talk to the women about when they do home visits or whatever, post-delivery. This is where prevention before cure. We have to address them that how to do their pelvic floor exercises. It should become their routine part of their life. Even when they're doing their activities, daily activities, looking after their child or cooking, they can still do their pelvic floor exercises. The last but not the least, E was very good in mentioning about Indian therapies, which is yoga. Yes, we should emphasize on yoga because again, that is also preventive. And it's very interesting, randomized control trial has been started in Birmingham for recurrent urinary tract infection. They're looking at the placebo therapy and acupuncture. So watch the space about whether the acupuncture does help or not. That's about it. Is there any question?
Dr. Manjula, if I could add one thing. Yes, pelvic floor exercises postpartum, we all emphasize, but rightly told by both the speakers, and I personally feel it because I have already told that I have personal experience in my house right now. I think the role of a physiotherapist in the elderly age group, even Dr. Lakshmi will agree with me, in Indian scenario, we are missing that. So that's a area where probably we gynecologists can start working and make wonders in elderly patients' life, because we are also going to be there one day soon.
Yeah, Anjali, I can correlate with you because I have got my mother, she's 92 years old. So I know all these problems, and it sometimes really becomes frustrating when we really can't help them out. Yeah, Manjula, there are 2 questions if you would like to answer. Yeah, in Q&A.
Do you want to read that, Lakshmi? I'm not able to access.
I will read. The first question is, if old patient comes with history of angina, can we use topical estrogen for long duration, or it should be used only for limited time?
It can be used as, again, I will go back to our Professor E's talk, that the use of estrogen long-term is equal to only 1 tablet. And it is local estrogen, which acts within the vaginal epithelium. It's not going to get into systemic circulation. So we have a lot of patients who have got ischemic heart disease and stroke patients, which still give them local estrogen therapy. And it can be used long-term. When I say long-term, it's lifelong.
Yeah, there is one more question. So when in timeline, the treatment, then Botox and bulking agents and others will be used. The role of Botox and bulking agents, when they should be used.
Okay. The bulkamide is only for stress incontinence. That's only after they have done their lifestyle modifications of reducing the weight, doing pelvic floor exercises. Then you can do the bulkamide injection. I emphasize it's only for stress incontinence. And Botox is usually in UK, we start them with lifestyle modification, bladder retraining, anticholinergics. Again, on anticholinergics, if they've tried 3 different anticholinergics, and if that has not helped, then we go for intravesical Botox injection. But again, please educate the patient that lifestyle modification, diet, Coke, coffee, all this is very important to cut down on it. Even Botox doesn't work on its own. Also use low dose, which is 100 units, and it can be done under local anesthesia. And please warn them, out of 10, in one of them can have voiding problems, which will be like retention of urine post-Botox, which is a short term, which is probably 8 to 10 weeks. They should be willing to do self-catheterization if it is possible, or if for frailty or other reasons, if they can't do, then they should be willing to have a Foley's catheter for that period of time post-Botox.
Yeah. Yes, Jyotsna?
Lakshmi, I just wanted to add one thing coming from the HRT side of it. I feel that Indian subcontinent feel very wary of HRT, but vaginal estrogen, practically speaking, there are not any contraindications to it. Even systemic HRT can be given transdermally if they have history of MI or if they had any other risk factors. But vaginal estrogen is extremely safe. It can be given lifelong, and it is absorbed minimally into the circulation. So if anything you can feel safe and secure about is vaginal estrogen. So feel very free to prescribe it, particularly in this age group of women, which may make a huge difference.
If Dr. Lakshmi will permit me to ask a question,
yes.
They have talked about the ring, vaginal ring, and rings are not still very easily. I will not say they are not available in market, but we are not using it for in this particular indication. So, what is the difference between the gel which we use as estradiol or Premarin gel and the ring? What is better? And as told, can even the gel be used for a very long time?
So basically, thank you for that question, because again, there's a difference between the preparations which are available here and in India, right? At the end of the day, that is just a preparation, different kind of preparation, the rings we're talking about. You can use any vaginal preparation. Just mindful about the concentrations in it. Some of them here, at least, they come a little bit different in the concentration, but technically speaking, any vaginal preparation, for example, Vagifem pessary, which we use, or the gel which we use, the starting dose is like once every day, then alternate day, and then twice a week can be a maintenance dose. However, sometimes women need more than that, and sometimes we give them more frequently, and they can be on it for lifelong. So it doesn't matter whether it's a ring or a gel or a pessary, whatever is available locally to you, and whatever is its strength and the recommendation to be used, you can use it.
Thank you. Thank you.
Yeah, Manjula, back to you for your concluding remarks, and then Sushma will propose vote of thanks here.
Thank you. Not much to add. Excellent talk. It was so nice to see all my colleagues across the globe. Hopefully, we'll meet in person. But thank you to Lakshmi and Jyotsna. Really, thank you for adding for us to this team. And I can't thank enough my two speakers, Professor Omohani and Eid, on a Sunday. We know, like, we look forward for weekend to have a break, but they have given their valuable 2.5, almost 3 hours for this session. Thanks everybody, even for the organizers and everyone. Thank you.
Thank you, Manjula. Jyotsna, there is one more question. What about breakthrough bleeding or postmenopausal bleeding with local estrogen?
Breakthrough bleeding with local estrogen. If you're talking about vaginal estrogen and she's not even taking any systemic HRT, the chances of breakthrough bleeding is extremely rare.
And
if anything, their breakthrough bleeding is possibly because of atrophic vaginitis. And if you put them on estrogen, it should resolve it. You cannot ignore it. So you'll have to do a local examination, speculum examination maybe. In fact, transvaginal ultrasound scan is not even recommended to measure their endometrial thickness because it is so slightly absorbed. If anything, if atrophic vaginitis is causing breakthrough bleeding, your vaginal estrogen should be the treatment of choice. It won't be other way around. Very, very, very unlikely.
Can it cause postmenopausal bleeding if we are giving it to a 75-year-old woman for a prolonged period of time? Local
No.
estrogen.
So, yeah, local vaginal estrogen, the current, even the recommendations don't even need to do any endometrial monitoring. So here we are talking about endometrial thickness rather than vaginal. So if anything, if it is atrophic changes of vagina, it should respond to estrogen.
Yeah. Sushma, for official vote of thanks. Yeah.
Thank you, ma'am. Thank you very much. For me, it's a great pleasure to be a part of this wonderful webinar with such a senior and wonderful faculties. It has been a wonderful webinar packed with knowledge, and on behalf of team of Indo International Web Series in association with RCOG License Group, I would like to extend my sincere thanks to Dr. Lakshmi Shikhande ma'am and Dr. Jyotsna Pundir ma'am for putting lots of efforts in organizing such webinars. I would like to extend my sincere gratitude to Dr. Manjula Anappa ma'am from UK for doing her job beautifully and taking time from her busy schedule and coordinating for the webinar. And from bottom of my heart, I would like to thank Dr. Fidelma O. Mahoney ma'am and Dr. Yi Ling Chen ma'am for their elaborate lectures on recurrent UTI and urinary incontinence. And then I would like to extend my thanks to our eminent moderators for the panel discussion, Lakshmi ma'am and Dr. Manjula Anappa ma'am, and panelists Dr. Manoj Aglave sir and Dr. Subhash Malia, Dr. Jyoti Banglowala and Dr. Deepa Mukundan and Dr. Anjali Kanare for giving us deep insight on the topic and making the panel discussion very interesting. And now I would like to thank our chairperson, Dr. S.P. Jeswar, Dr. Mala Srivastav, Dr. Tabassum Dalla, and Dr. Anil for chairing the session and sharing interesting facts. And at last, and but not the least, I extend my gratitude to Dr. Jyoti Malik for conducting this webinar smoothly and putting enormous efforts in making this webinar a huge success. Thank you, Dr. Lakshmi Shikhande ma'am, Dr. Jyotsna ma'am, for giving me the opportunity to be a part of such a esteemed platform. Thank you very much, ma'am. Thank you very much.
Thank you, Sushma, for wonderful coordination.
Thank you,
and
madam.
thanks, Team Walter Bushnell, for providing us
Thank you, ma'am.
technical support. Yeah.
Thank you, ma'am. It gave us a beautiful insight and wonderful opportunity to interact with all the national as well as international delegates. We like to conduct such kind of scientific.
It is a very clinical approach for this webinar is very good, and I think it is useful for each and every one of us because we are dealing with UTI in all age groups. So it's a wonderful.
Agree. Thank you, Dr. Lakshmi. Thank you so much. Thank you, Dr. Lakshmi. Actually, this subject is quite, but it's a difficult to understand and manage also. So sometimes patient does not come and complain, and in day-to-day life, many women suffer from this. So nice discussion. Thank you. Thank you so much.
Thank you, ma'am.
Thank you, because you chose two very practical topics which we all gynecologists are seeing in our day-to-day OPD practice: urinary incontinence and UTI, because they first come to us. In India, I mean, if she's a female, so she will go to a gynecologist first. So fantastic. Hats off to you for the selection of topics, selection of speakers, and your 3 case discussions.
Oh,
Thank you, Dr. Lakshmi. Thank you so much.
Thank you so much.
And thank you,
Thanks,
Jyotsna,
Dr.
for
Lakshmi.
connecting me to Manjula.
Thank you.
Cheers.